shame on you. You'll start to see, hey, wait a second. This one medication treats seizures, bipolar depression, and migraine headaches. Well, that's weird. And then you later on may start to notice that people with migraine headaches may have bipolar disorder, or vice versa, or people with seizures have bipolar disorder, or all three. There's a connection there, okay? And I'm not the authority on it, but anyway, you should think about things like that. So skip on over to page 256. This is Parkinson's management. So Parkinson's is a dopamine deficit. First, we've got a neuromuscular part, rigidity, the cogwheel motion and all that stuff. So that is a matter of acetylcholine, too much of it. Okay, so we want to prescribe anticholinergics. So look on page 256 on the right-hand side, middle. Talks about the anticholinergics. They cross the blood-brain barrier easily. They work fairly well. The book talks about cogentin being a good one, and it actually is. I'm probably not even going to worry about any particular anticholinergic drug. If I do, I will put in parentheses, this is an anticholinergic. But the question is going to be more about a Parkinsonian patient who has, worsening rigidity. How might we treat this? Okay. Dopamine agonists. These are medicines that make dopamine that's already in the body work better. Okay. Mirapex and Requip are very common, and this is a sideline, but Requip and Mirapex are also good for restless leg syndrome. Main side effect that can come from these, though, is a tardive dyskinesia, though. Like the Joker was doing all the time in that Dark Knight movie, which is awesome. And that tends to be pretty permanent when it does happen. Doesn't go away. So be careful with that. But when you have Parkinson, depending on the degree of Parkinsonian, the benefits may far outweigh the risk. And then, of course, one of the mainstays of the dopamine precursors, carbidopa, levodopa, Cinemet. And then there's another one, carbidopa, levodopa, and entacapone. So the main thing is these are precursors to dopamine. They don't cross the blood-brain barrier easily, so one half of the medication is helped to enhance the other so that it can do that and increase dopamine. One thing that I have noticed in my patients who are on that, they may become too well managed on Cinemet. I've had patients who come in almost zombified because it has actually caused them to have too much dopamine. So be careful with that, but otherwise, it is a very good medication to use for the treatment of Parkinson's disease. Okay, now, COMT inhibitors, COMPT, COMT inhibitors. This is an enzyme that inhibits the production of dopamine from its precursors, catecholamines. So a COMT inhibitor inhibits that enzyme from doing that so that your body can actually produce the dopamine that it's supposed to, okay? All right. There's a little deal about monoamine oxidase inhibitors on page 260. This can be helpful. It says it helps slow the progression of the disease. In my experience, not a lot of neurologists prescribe these unless it's just last-ditch effort. There's a lot of things that go along with monoamine oxidase inhibitors, and sometimes they're not very effective, okay? All right. Next topic it talks about is Alzheimer's disease, fairly common. This is a dementia. I call it Alzheimer's dementia, not Alzheimer's disease. That doesn't change it, it's just what I call it. Anyways, this is kind of the opposite of the rigid part of Parkinson's where we have too much breakdown of acetylcholine. There's not enough going on. Um, and then there's the basal ganglia damage, all that stuff that goes into the Alzheimer's dementia. Um, this the treatment of of this condition is to slow progression. So far, we don't have a cure. I know you know that, but so we're talking about slowing it, and it can be difficult to treat. Believe me, I see it in the hospital because people come in with a sudden progression of their dementia, and it can happen just like that. And sometimes there's not much to be done about it. Aricept, Exelon, these are excellent medications for the treatment of it to slow it. Um, these are listed on page 263. Then we have memantine or Namenda, which is play off of the actual NMDA. Uh, and what this does, there's a complex system that basically, and you can read all about it on that page. Basically, Namenda is designed to reduce membrane excitability. That was a fly that just flew past my head. I don't know how it got in here. When you're prescribing Namenda, and I'm saying this because it sounds like a good quiz question to me, always get a baseline liver function. Liver failure can happen from that, okay? Next, it talks about multiple sclerosis. So I've diagnosed this in the hospital, and what I was saying earlier is it's not good to diagnose it in the hospital. It's too long and drawn out. And it's not an easy diagnosis to make at all. Multiple presentations, very difficult. But I actually had a case that I was pretty sure, and I actually got some good results that were pretty confirmatory. So what did I do for this patient? Steroids. I gave her steroids to reduce inflammation, and I got her to a neurologist quickly because they know how to treat this. I did not. Anyways, medications for the treatment of multiple sclerosis are on table 413. These are medications that, I mean, a neurologist is going to prescribe them. They're usually treatments that are given at the neurologist clinic, and there are all kinds of advances in multiple sclerosis medicine right now that I heard of a new one just the other day that I haven't even researched yet. Just know that this is, these medications are for disease modification. We're talking about the brain itself breaking down the sheaths on the axons, the myelin sheaths. So we're trying to slow that progression, and that's where steroids can help by reducing inflammation. But that's not even in the book, so I don't want to get you all jacked up on that. Okay, and then the next topic is peripheral neuropathies. You'll probably see a ton of that: diabetic peripheral neuropathy, essential peripheral neuropathies, restless leg syndrome. Just remember that these can all be treated by several different medications because it kind of goes back to the basic principle I was saying. This all stems from the brain. So many of these medications do very similar things to the brain. So what they treat one thing, they'll treat another thing. So restless leg syndrome, and this part's not in the book, but just FYI, when I talk about Requip and Mirapex, that's really good, and it helps. Peripheral neuropathy is very common, especially amongst your diabetic patients. And the same medications are pretty decent for treatment of this, even whether it's diabetic or non-diabetic. I like to use gabapentin as a first-line treatment. Number one, it's affordable. Number two, it works fairly quickly. And you've got a pretty good range to titrate it to effect. Now, you can have too much gabapentin. I have people who come in who are obtunded for really no known reason, and I don't have anything obviously sticking its head out as that damn fly. First thing I'll look for is neurontin because it can really depress someone centrally. But it takes a lot for it to do that, so it's good. Then, of course, we've seen the use of Cymbalta, Lyrica, other antidepressants for the treatment of peripheral neuropathy. It's also used to treat fibromyalgia. Those things work better. That it's really there's no difference. It's a matter of cost. Cost is always the inhibiting factor for every medication. So, if your patient has insurance to pay for it, that's fine. But as far as the test or quiz goes in terms of treatment of peripheral neuropathies, I may say something like, hey, patient X comes to the office, you've treated their diabetes for a long time. They've had recent complaints of numbness and tingling in their legs, feels like they're walking on pins and needles. This is a diabetic peripheral neuropathy. How might we treat this? Or maybe which of the following is not recommended for the treatment of that? Okay? That's all the book talks about for neurological conditions, and I think that's plenty, believe me. Let me stop this lecture and slice it up for YouTube, and I'm going to try to kill this fly, and then I will be back with the psychiatric lectures.